Today I'm going to talk about exercise intolerance and the pathophysiology of HFpEF, heart failure with preserved ejection fraction in the older adults. And I know some of the participants on the conference have an interest in HFpEF, and that's been a passion of mine for a few decades. And that's what we'll focus on in the next sort of 35 to 45 minutes. So as a little overview of my presentation, I will briefly talk about the global burden of heart failure, in particular, why exercise intolerance is important to study in heart failure patients, specifically heart failure patients with preserved ejection fraction. A term I will use a lot today is something called peak aerobic power. It's just a measure of your cardiorespiratory fitness or your overall fitness. It's an important outcome because in every population in health and disease that it's been studied, it's the single best predictor of how long you live. So for those aren't familiar with exercise physiology, that's okay. I'll show a slide that highlights the fitness levels from elite athletes all the way down to our heart failure patients, and then some heart transplant recipients. And I'll talk about some of the mechanisms underpinning the reduced exercise intolerance in HFpEF. And I'll just finish off a little bit about exercise training in HFpEF and its importance for cardiac rehabilitation, both its supervised and unsupervised, and especially important role of nursing plays in this particular therapy. So as you're likely aware, heart failure is a major healthcare problem. It's estimated that 64 million people are living with heart failure worldwide. And the prevalence of known heart failure is estimated to be around 1 to 2% of the general adult population in developed countries. So it's a major healthcare problem. Over half of all our heart failure patients in the general population have a preserved ejection fraction, which is around 50%. But interestingly, as we age, a normal ejection fraction may be 60%. So it's possible that some of the individuals that we're calling HFrEF may be heart failure with a mid-range ejection fraction or even HFpEF. And it's really important because HFpEF is the most common form of heart failure in individuals over 65 years of age, and especially important to over 80% of our new cases of heart failure or HFpEF, especially in older women. So the typical phenotype of HFpEF that we see in a lot of the exercise trials that I've performed or been involved with, our HFpEF patients are often older. They often have a higher body mass index or obese, as well as having a higher blood pressure, sedentary lifestyle, as well as some atrial fibrillation. As I said, HFpEF is associated with a high morbidity and mortality, and the prognosis is often dismal. After hospitalization, the 5-year survival of HFpEF is 35%. And numerous of studies, including work we've done over the years, have examined the mechanisms of exercise impairments in heart failure and reduced ejection fraction. And for those who are not familiar with this phenotype, these are our patients that are often underlying etiology of myocardial infarction or idiopathic dilated cardiomyopathy, where they've got a large heart that's dilated, that doesn't pump out very well. But there's really not a lot of data available regarding the mechanisms of the lower exercise intolerance in HFpEF. And the phenotype, again, for a heart morphology is a large mass. The walls are thicker. This ventricle does not often fill with blood very well, or does so at very high filling pressures. And the ventricle is stiff, but so is the vasculature stiff. So the coupling of blood from the heart out into the blood vessels is impaired. And we call that impaired ventricular vascular coupling. A lot of the work we've done in the last number of years have also highlighted that although the heart is a problem, we also have to look at what we call non-cardiac peripheral limitations, so the skeletal muscle. So I'm going to focus a lot of my talk on that area because this is a gero conference, and as we age, we lose muscle mass and we lose muscle strength, and we have a term called sarcopenia, the age-related loss of muscle mass, or sarcopenic obesity, where we lose muscle mass and gain fat. And that's often common in our heart failure patients with preserved ejection fraction. I highlight skeletal muscle because there's a lot of plasticity, and it may be a target of therapy that we can improve the fitness in our heart failure patients who have a normal ejection fraction. And again, as I said, our understanding of heart failure with preserved ejection fraction pathophysiology is incomplete. And unlike HFrEF, where we have proven efficacious therapies, the optimal treatment remains uncertain. So why is it important to talk about exercise intolerance? Well, it's important to talk about exercise intolerance because it's the cardinal feature. So when our heart failure patients are coming to your clinics, coming to your cardiac rehab, or coming for nutritional assessment, when you start asking them how they feel, the first thing they often will tell you is I really short of breath and fatigued when I do activities of daily living or even little mild level of exercise. And I'm going to show you why from an exercise physiology that is. And one of the slides I'm going to show from a colleague and friend of mine, Greg Lewis at the Mass General in Boston, they kind of modified a slide that we published a number of years ago, and they've really added to it very nicely. But it'll be surprising to some of you when I show you what level activity actually causes fatigue in our HFpEF patients. Quite shocking, but we can discuss that after. But our heart failure patients, the cardinal feature is exertional dyspnea. I'm short of breath, I'm fatigued, and they're the hallmark symptoms. Reduced exercise tolerance or decreased exercise capacity, cardiorespiratory fitness, or peak oxygen uptake is a major contributor to the impaired physical functional performance. It's associated with reduced quality of life, and a number of studies have demonstrated it's a strong predictor of mortality in HFpEF patients. So HFpEF patients with the lowest fitness also have the highest mortality. Jess Scott, when she was with our group and with Delane Kitzman, some work from their lab, and it's demonstrated that peak VO2 is very standardized, it's objective, it's highly reproducible, even in older HFpEF patients. So let's talk about exercise for a second here. Again, it's a passion of mine, and some of my training has been obviously, or most of it, in exercise physiology. And what you'll see here is on the y-axis, we have this term called VO2 max, or your maximal oxygen consumption. That's just the maximum rate that you're able to take in oxygen from the atmosphere, transport it through the lungs to the heart, through the vasculature, and ultimately to the mitochondria will be utilized to generate ATP in the form of energy, and so you can do work or exercise. So just as a sort of a highlight that you can see what are some of the upper limits and lower limits, this is just some data that I found in literature for elite male marathon runners. And when you see 90, this is just a value that's your oxygen uptake indexed to your body mass. So if this person weighed 50 kilograms, their absolute VO2 would be 4.5 liters if my math is correctly. So around 90 mils per kg, very high VO2 max. One of the highest recorded VO2 max in elite marathon female athletes is actually the individual who currently still holds the world record in the UK. It's 75 mils per kg. This is a really fascinating story here for this individual in yellow. This person is an individual who competed in the Boston Marathon de Mar, 32 times, of which he won Boston 7 times. And I think one of the first times he was on the starting line of the marathon, they would do some little auscultation and listen to people's hearts. And they're like, this individual's got a murmur. You should never be exercising. So he took a little time off, and then he came back the next year and won the marathon and competed it 32 times. And his score, I forget how old he was. He was quite old or older age when he scored 60 mils per kg. Young athletes have scores around 57 mils per kg. And then as we age, after the age of 25, our fitness level will decline by 10% per decade, or 1% per year. And unfortunately, that is a consequence of aging. Unless you're a master athlete, you can attenuate that decline. And older sedentary individuals have a score of 26. Individuals I've worked with over the last 2 decades have scores around 13 to 14. So you can compare that 13 to 90. There's no way a heart failure patient's ever going to become an elite marathoner. And this is really interesting because when now you have a heart transplant and you have that now donor allograft, although it is denervated, at least functionally, although we have some papers we've published where there's some reinnervation of the heart, the scores for most heart transplant recipients only go up by about 6 mils, maybe a couple mets. what we find is a lot of our heart transplant recipients become sedentary post-transplant. They kind of adhere to a lifestyle they adhered to prior to that. Although we've published a couple of cases of some heart transplant recipients who are athletic before, who now are actually competing in elite competitions, including the Ironman World Championships. One thing I would just like to highlight real quickly is why we don't want to sit around and do nothing is based on the classic Dallas bed rest study that was published in 1966. And it was actually performed by Jerry Mitchell and Bengt Saltine at the University of Texas, so UT Southwestern. It's the seminal study. There was 5 males who participated in the study. And as part of the study, they were required to adhere to strict bed rest for 20 days or 21 days, 3 weeks. And they measured all these fitness measures before and after, as well as a number of other outcomes of their heart size and their pulmonary function and lean mass and everything you can imagine. And they did some exercise training. But the unique aspect of the Dallas bed rest study, which today I still think is one of the seminal studies and best studies ever published, even though it's a small n, is that they brought these 5 individuals back 30 years later and 40 years later. And it's sort of interestingly, the lead author of the 40-year follow-up was my first PhD student, John McGavick, and he did a postdoc at UT Southwestern with Ben Levine and Jerry and a number of other individuals, and he actually did the 40-year follow-up with that group. The main important point of what I'm trying to get at in a long roundabout way is when they measured their fitness, it declined after 3 weeks of bed rest. But how much did it decline? Well, it declined so much that when they brought these individuals back 30 years later and 40 years later, the decline in their fitness after 21 days of bed rest was equivalent to the score that they observed when they brought them back when they were 60 years of age. So 3 weeks of strict bed rest is associated with a decline in VO2 that's equivalent to 40 years of aging. So where possible, where individuals are clinically stable and where we can, it's critical that we get patients up and moving and doing some physical activity and importantly, exercise, because you lose a massive amount of fitness by sitting and doing nothing, sedentary bed rest deconditioning. So that's really a highlight, is that 21 days of bed rest is equal to 40 years of aging. So getting back to our heart failure patients, this is a beautiful slide by Greg Lewis's group that they published in a nice review in Journal of the American College of Cardiology Heart Failure in 2020. Here's VO2 peak again. Now remember that 90 is the fittest, very, very high. We're seeing peak VO2. This is, I think, from a number of studies, Greg took the average of around 15 mils per kg. This is a term we call the anaerobic or lactate or ventilatory threshold. This is also an important measure that we can quantify when we have people on performing a cardiopulmonary exercise test, either on a treadmill or a bike. And what we do is people have a mouthpiece on that's attached to a hose that's connected to a metabolic cart, and we can measure how much oxygen you're consuming. Now, this threshold is a term we use in physiology of exercise where you start to use not only aerobic energy sources, but anaerobic energy sources. And the byproduct of this anaerobic glycolysis is hydrogen, and that leads to fatigue. So, you know, if you've ever been exercising or going up a hill or sort of ramping up your exercise you're doing, and you start breathing a little bit more deeply and quicker, likely as you're reaching your ventilatory threshold, and above that, you start to fatigue. Okay, so let's get back to this slide. Why it's really important here is their fitness is around 15. Here are activities of daily living or the oxygen cost for functional independence. So what they're saying here is resting requires 23% of the peak oxygen uptake of many HFpEF patients. This is a very, very important next little sort of number here. Just getting dressed in the morning or at night or throughout the day or making your bed requires 60% of your maximal effort when you have low fitness. So when our heart failure patients tell us they get fatigued just doing activities of daily living, of course they do, because their fitness level is so low that just making your bed requires about 9 mils per kg, but their maximum is 15. So why this is very important is because we often give exercise guidelines, and I'll provide some, but we often say at 60% of your maximum or 50. But remember, if you're really deconditioned, 50% of your maximum is equal to dressing. So you have to take into consideration everyone's fitness level when you're prescribing exercise. Because if you say, well, you should exercise at 50%, if your VO2 is 15, which many of our heart failure patients have a value of, then your cardiac rehab is simply take your shirt on, put your shirt on, take your shirt on, take your shirt off, and do that for 20 minutes. So you have to be very careful when you talk about exercise, because you have to look at the heart failure patient's fitness level. Vacuuming and sweeping requires 70% of their maximal effort. Walking 3 miles per hour or 1.5 miles in half an hour is almost 80%. Activities of daily living require a score of around 15 to 18 mils per kg. So what that means is again, most of our heart failure patients do not have a fitness level that allows them to functionally independently in their environment. So what we do is we often call them walking anaerobes. Our HFpEF patients will do a little bit of activity for 30 seconds to a minute, take a break. 30 seconds, to a minute, take a break. And they might walk up a flight of stairs. Oh, I need to take a break. Or carry a grandchild. They can do that for a little bit, take a break. Again, carrying wood or groceries, 129% of your maximum, and forget about jogging 5 miles an hour because it's around 200% of your maximum. Very few of our HFpEF patients can do that. So again, this is really important to think about because it really is consistent with what people will tell you when they come to your clinics. And you may objectively ask them from the New York Heart Association, what makes you tired? But it's all going to be relative to their fitness level because they actually may be class 3 in virtue of having low fitness, and just dressing or making a bed makes them tired. Okay, so really think about this. Now, why this is important is that with exercise training, we can improve your peak VO2 and your threshold by about 2 mils per kg. So if you're now able to improve to 17 mils per kg, making your bed or dressing now only requires 40% of your maximal effort. Sweeping might be 55, walking maybe only about 70. So it's really important. We believe that if we can get you above your threshold for independent living, you'll do more in your activities throughout your environment and feel better. So that's the importance of being physically active, because we get you above this threshold level for independence. The worst thing you want is for older heart failure patients who also have osteopenia and process with balance problems is to fall, fracture, now be in bed for 3 weeks and they never get out of bed. Okay, this is a slide I love to show. It's from Greg Lewis's group. Again, Nick Hustis was the first author, but really this slide comes from Ewald Weibel from Nature. And anything along the oxygen cascade, as I said, from the environmental oxygen that you breathe in, that via alveolar ventilation and lung oxygen diffusive capacity that's carried by hemoglobin and convectively delivered throughout your large arteries down to the periphery and the microvasculature. Again, that's diffused through the muscles. We call this term muscle oxygen diffusive conductance. This is a really important term because we're finding that one of the major limiting factors to exercise tolerance is impaired muscle oxygen diffusive conductance. And that's the transport of oxygen from the microvasculature red blood cell that diffuses down to the muscle mitochondria. And this little area in here is all the metabolic and inertia that resists this flow of oxygen to the muscle mitochondria. This is important because we believe this has a large plasticity, and to the date, all the evidence would suggest that this is how we improve your VO2 through exercise training in HFpEF. In HFrEF, we can improve your cardiac output with exercise training by improving your vascular tone and making it more compliant. But evidence to date that we've published in others and a few studies show we don't improve your cardiac function. It's all periphery. And I'll focus on that. Now, this is a nice review that Wes Tucker, who Kathy and Elisa and some of my colleagues will know this name. Wes was a postdoc at UTA. Now he's at Texas Women's University, and he worked with Mike Nilsson and I as his postdoc supervisors. And we published this nice little review a few years ago that we were invited to do so. Again, it's just showing that in accordance with what we call the thick principle, where oxygen uptake is equivalent to your cardiac output and your arterial venous oxygen content difference, these are factors that can limit your performance. So our heart failure patients, both with reduced and preserved ejection fraction, have a lower cardiac output, but they also have a lower arterial venous oxygen difference. And I'll just spend a couple minutes highlighting some of these things that are limiting performance. not unlike individuals who are older. And as we age, we have what's called chronotropic incompetence. We have downregulation of our beta cells in our heart, and we're not able to increase our heart rate as much as we are able to do when we are younger. So our age-related maximal heart rate decreases um, throughout the whole aging continuum. That's just your heart rate or heartbeat at maximal exercise. Stroke volume, for those who are not familiar, is just the amount of blood you pump out with each beat. And our heart failure patients with reduced or preserved ejection fraction have a lower maximal heart rate or peak exercise heart rate. Our HFpEF patients also have a lower end diastolic volume. That's the amount of blood that sits in your ventricle when the heart is fully relaxed. That's lower. Our HFrEF patients have much higher end diastolic volumes because their hearts are dilated and they have dilated cardiomyopathy. Whereas our HFpEF patients, they have larger left ventricular mass and greater heart size, but they have smaller chamber and very thick or thicker walls. Why the end diastolic volume is lower is for a number of reasons, is that the chamber is more stiff or less compliant. So these thicker walls in pathology are stiff and they don't fill as well with blood. Also, a heart does three things. It contracts, it relaxes, and it fills with blood. In both HFrEF and HFpEF, the relaxation, or what's called the time constant of relaxation, is impaired. So with a greater tau, that means when the mitral valve opens, the ventricle has got a higher filling pressure. And at any given volume, a higher filling pressure at any constant volume is a stiffer ventricle. And that's measured in the cath lab or in an exercise hemodynamic lab as an elevation in directly measured left ventricular end diastolic pressure, or with a Swan-Ganz catheter as an increased pulmonary capillary wedge pressure. And centrally, we also have an increase in pulmonary vascular resistance and peripherally as systemic vascular resistance. And we have some abnormalities in lung function as well. There may be some VQ mismatching and increased work of breathing. Now on the periphery, as far as your content of arterial and venous oxygen difference, our HFpEF patients as well as HFrEF often have lower hemoglobin. So that's going to affect your oxygen carrying capacity. And in the microvasculature, both HFrEF and HFpEF have some microvascular dysfunction. Although it would appear in HFrEF, they have more microvascular dysfunction. And again, this transport of oxygen from the the red blood cell microvasculature to the muscle mitochondria, this diffusive conductance is markedly impaired. And as a side, if all you do is increase cardiac output and increase the pump, but you don't improve the peripheral component, this muscle diffusive conductance, then what happens is your fitness may actually not go up. Because although cardiac output goes up, if you increase flow to muscles that either can't diffuse it or utilize oxygen, in essence, what happens is we have a shunt. And your venous oxygen content paradoxically will go up, not down, in a setting of a higher cardiac output and muscle blood flow where the muscles can't diffuse or utilize oxygen. So we have to look at our HFpEF patients individually to see along the O2 cascade, what is their limitation to phenotype them correctly and provide interventions, maybe nutritional or exercise, to attenuate that weak link. So we have reduction muscle diffusive conductance. Why? Because we've got greater surface area for diffusion, because we have less capillaries. And we may have some also some microvascular dysfunction and some fluid in the interstitial space, as well as our HFpEF patients have lower type 1 oxidative, which are fibers in the muscle, which are our endurance athlete fibers. You'll see long distance runners, ultra endurance athletes, cyclists at the elite level have very high percent type 1 mouse and heavy chain oxidative fibers. Our HFpEF patients have lower oxidative fibers and lower oxidative enzymes, which coupled with decreased mitochondrial volume and density result in a cascade in which we must rely then on anaerobic sources of energy, which, as I've already said, result in anaerobic glycolysis and early fatigue during ADLs and low levels of exercise if you have low fitness. So very hard to change this, much more easier to improve on this periphery in our HFpEF. So let's talk about this for a little bit. This is a beautiful study by Josh Lee, who was a PhD student with Matt Brothers, and then went on to the group to work with the vascular research group in Utah. And they published a really elegant study with a small number of HFpEF patients who were 68 years of age and 71 years of age of control. Elegant study in the sense that when you only engage one muscle, the quadriceps, by doing one leg knee extension. So if you're all sitting there right now, like I am, sit up straight in your chair and just kick your right leg out, bring it back. Kick your leg right out, bring it back. Don't move your hip, just extend and flex at the knee. That's called unilateral knee extension. And Bent Saltine, who is the godfather of exercise physiology, developed this bike in Karolinska Institute. And it's just a cycle ergometer that's attached to a flywheel. And we actually have this bike in one of Kathy's labs and my colleagues' labs in the beautiful Sear building. And why this is beautiful is that when you only engage 5 or 6 kilograms of muscle, the heart is never limiting. So it's a wonderful modality to look at the limiting role of exercise when the limiting role of the heart is minimized. So what the heart failure patients and the controls do is they start kicking with their leg with no weight, and then we add a little bit of resistance from 1 to 3 watts all the way up to 15 watts at the end. And most of our heart failure patients can't do much more than that. And we incrementally increase the power output. And on the y-axis, here in A is blood flow, mean arterial pressure. And if you look at these combined together, we get something called leg vascular conductance, which is just the inverse of vascular resistance. So if conductance is lower, it means your resistance is higher. And what they found in the HFpEF patients at 10 watts or 15 watts, which is very low level exercise, it's like having your leg kicking, like I said, with maybe a 5 kilogram leg weight attached to it, and you do that repetitively for a minute, our heart failure patients would have lower blood flow. But interestingly, their hearts aren't limiting during this. So something's happening in the peripheral vasculature whereby even though the heart is dysfunctional, it still can supply enough blood, or theoretically should supply enough blood to the muscles, but is unable to. So something is happening at the microvascular or the larger vascular level in the femoral region, and distal to that where we're not getting blood like we should. And one of the reasons is this conductance is lower and our vascular resistance is higher. So when you and I exercise, we increase sympathetic tone to our muscles, which should actually cause your muscles to vasoconstrict or get smaller blood vessel flow. But we also have local metabolites in the muscle that say, hey, I need more blood flow. And as a result of this battle between the local metabolites and the sympathetic nervous system in health, the local metabolites will win, and they will release certain substances that cause vasodilation in the vasculature, and you increase blood flow. But our HFrEF and HF patients have what we call impaired functional sympatholysis, and paradoxically, they will constrict when they should dilate. And that leads to less blood flow. And we have world expert at UTA, Paul Fidel, who studies this. So we're very fortunate because we've got the world leaders at UTA in looking at vasculature and microvasculature. So anyone who's interested in this area, look up the name Paul Fidel and Matt Brothers and others there, because they are the world leaders in this whole area in health and those individuals at risk for heart failure and heart failure patients. Just a good shout out for my colleagues at UTA, world-class institute for nursing and physiology research. Okay, so let's talk about muscle mass again now, because that's what I'll focus on for the next little bit. Listen, as we age, we lose muscle mass. And the seminal study by Jerry Flegg and Ed Licata with the Baltimore Longitudinal Study in Aging demonstrated that when we age, we lose muscle mass and we lose fitness. But when you count for the age-related muscle mass, the loss of fitness is markedly attenuated, which makes sense because 90% of the working oxygen that's being consumed is in the working muscle. So if you have less effective muscle, you can't utilize as much oxygen. So what we did, and my colleagues, Delane Kitzman, conducted this at the Baptist Hospital at Wake Forest, and we had 60 HFpEF patients and 40 age-matched controls. The body, if we look at their peak VO2 index to their body mass, it's significantly lower. If we look at their peak VO2 relative to their whole lean body mass measured by dual X-ray energy exaptometry, DEXA scan, still lower. And when we look at their VO2 by their leg lean body mass, this is important because we exercise them on a cycle ergometer, it's still lower. So in a roundabout way, what I'm saying is that when you count for muscle mass losses with age or in heart failure, the fitness level is still lower. And that's just shown here. VO2 on the y-axis, percent lean leg mass on the x-axis, and above 50% leg lean mass. This is the regression line for healthy controls. This is the regression line for HFpEF. It's markedly blunted so that at any given percent lean mass, the HFpEF patients have lower VO2. What this means is there's not necessarily a problem with the quantity of muscle, but the quality of muscle. And this next study highlights this very nicely that we published in AJC in 2014 from the Kitzman lab. And this study, MRI was performed of the vastus lateralis. And here is subcutaneous tissue, which the patients and controls were matched for. Red is their muscle mass, and green is intramuscular fat. You don't want a lot of this green. You want a lot of muscle, you want a lot of capillaries, and you want a high number of oxidative fibers if you're an endurance athlete. If you're a power athlete, sprinter, they have large muscles, but most of their fibers or higher percentage are type 2 glycolytic fibers, myosin heavy chain, less mitochondria, and they're very powerful muscle fibers. So what you don't want is a high green to red ratio. Well, look at our HFpEF subject. They have less muscle, the red, and lots of green, bad intramuscular fat. So the green to red ratio, which is this intramuscular fat to skeletal muscle ratio, is markedly and significantly higher, 38% to 28% in HFpEF. And this is bad because the more fat you have and less metabolically active tissue, one of the consequences is now that oxygen also has got to traverse a larger distance from the red blood cell to get to the muscle mitochondria, and it decreases muscle oxygen diffusive conductance. So our HFpEF patients have lower skeletal muscle relative to the thigh compartment and much more intramuscular fat to skeletal muscle or thigh compartment. And we see this wonderful inverse relationship between your fitness level and intramuscular fat. Those with the greatest IMF-SM ratio, i.e. HFpEF patients, have the lowest VO2 peak. Now, as an aside, we've done a lot of work with women with breast cancer. Elisa and Kathy and others and my group in Edmonton, we've been doing cardio-oncology for 2 decades. Well, a decade. What we're finding in our women with breast cancer, they also have very low VO2. They almost look like HFpEF patients. But we've recently reported, and Reese Beaudry did his PhD at UTA, and he published a wonderful paper where he found the exact same phenomena in women with breast cancer with low fitness. They have a large amount of fat to muscle ratio, even though their hearts are normal. So we actually think there's a large number with breast cancer because the leading cause now of death in women with early stage breast cancer is actually heart failure, not breast cancer. So what we're finding is there's some similarities, and one of which is high IMF skeletal muscle ratio. We also find, and don't worry about these, I'll just rip through this quickly because it's now almost 12 after 6 after, I guess, your time, 12 my time. Our heart failure patients also have a lower number of capillaries to fibers, so less capillaries that supply oxygen per fiber, and less oxidative type 1 myosin heavy chain moiety fibers. So, and what we also find is that those individuals with lower capillary fiber ratio and lower type 1 fibers here and here also have the lowest fitness level. And this was done by vastus lateralis muscle biopsy, where you can do analysis of the vastus lateralis and look at the morphology of the muscle. So again, this is a cascade now where you have lower type 1 oxidative fibers, lower capillary to fiber ratio, more fat, and this culminates in what would end up being lower muscle oxygen diffusive conductance. These all result in greater inertia of oxygen being transported from the red blood cells in the microvasculature to the mitochondria, or the mitochondria not utilizing oxygen as well. This all leads to fatigue because then you now must rely on substrate level phosphorylation which is just our creatine phosphate, or anaerobic glycolysis, and the byproducts there are lactate and hydrogen, and those are fatiguing byproducts. Excuse me. This is a nice review that Wes Tucker, again, published in Heart Lung Circulation. And I believe Wes actually won an award, and this was highlighted as the review of the year for that year in this journal. This is just looking at the mechanisms of improvement in peak VO2 with exercise training in HFpEF and HFrEF. Now, it's really interesting because both HFrEF and HFpEF have lower fitness level, but the mechanisms of the improvement in peak VO2 or exercise capacity, cardiorespiratory fitness differ a little bit. Overall, the improvement in VO2 peak is around 2 mils per kg. That number not mean much to you, but it's important because it's a value that now will take most of our heart failure patients who are below the threshold for independent living and get them above that. So they don't necessarily have to work as hard for activities of daily living to function in their environment with greater ease. There's only been a few studies looking at the mechanisms of the improvement with exercise training, of which our group has published several of those. Fitness will improve in both HFrEF and HFpEF roughly around the same amount. Cardiac output, or the amount of blood you pump out with each beat per minute, will increase with HFrEF as a secondary to an improvement in stroke volume in some studies, or no change or increase in heart rate. Unlike HFrEF, studies to date in our group, including, has shown that VO2 improves, but cardiac output doesn't change, maximal stroke volume doesn't change, and heart rate, like HFrEF, will either not change or go up a little bit. This probably goes up not to any intrinsic improvement in the heart itself. It's likely we exercise a little bit longer, increase your power output, and your heart rate just has more time to increase. There's no change in end diastolic volumes. And in fact, we published a beautiful meta-analysis in 2007, which is quite highly cited, which demonstrated that exercise training can actually attenuate remodeling, which is an unfavorable adaptation of the heart. We can have some reverse, I don't want to say reverse remodeling, but we can make the heart actually a little less dilated, and the ejection fraction at rest goes up. Evidence to date, now that's just at rest. We don't really know during exercise. Not that many studies have done exercise volume assessments because it's very hard to do. Again, no changes in volumes with HFpEF. Vascular resistance doesn't change or goes down, and this is for the most part why cardiac output goes up. As the vascular resistance is very tight, as you start to vasodilate, and have greater functional sympatholysis during exercise, the heart doesn't have to work as hard. It's like your garden hose. When you plug it, there's no flow. When you slowly release it, flow increases. So if you can attenuate that constriction, which exercise can do by improving vascular endothelial function in HFrEF, we get greater improvements in vascular tone. So the heart doesn't have to work as hard and there's less wall stress. Vascular resistance in the few studies that have measured doesn't change in HFpEF. And the improvement in VO2 peak is unequivocally and almost entirely due to those peripheral adaptations that I said were abnormal in HFpEF. We improve arterial venous oxygen difference, and likely we're improving muscle oxygen diffusive conductance. No one has looked at leg blood flow, which improves in HFrEF with exercise, or O2 delivery, which improves with HFrEF. No one studied this in HFpEF. And looking right at the leg level, no one's measured that in HFpEF, and they found favorable adaptations in HFrEF. So it appears that the limited data to date shows that exercise training improves your VO2 peak, it improves your physical functioning, it improves quality of life, and adaptation seems to be in HFpEF due to non-cardiac peripheral adaptations at the muscle level, but we're not quite certain mechanistically why that is. But my colleagues at UTA and at the Institute for Environmental and Exercise Medicine, with Ben Levine as the PI, have a wonderful program project grant, and they're answering this question, and they're performing the most definitive phenotyping and exercise intervention study ever performed to date in HFpEF patients. So in a few years, you can anxiously look for those results. Just as I will finish off here, it's really important when we talk about nursing as well as nutrition and occupational physical therapy and the physicians and the physiatrists that we really have a multi-collaborative team, and we have to think about the heart failure care and the transition of care. Again, cardiac rehab really should start early in the hospital where possible, because after 3 weeks of bed rest, younger individuals age by 40 years. What do our heart failure patients? There's only so much they can decline their VO2 and it's already 15. So we have to look at transition of care. We have to incorporate the patient and the family, the cardiac rehab team. And the US, much like Canada, although we have a healthcare system that's quite unique in that we all have access to healthcare, cardiac rehab referral is poor. Only 1/3 of patients are referred and many don't ever attend. When I used to go to the cardiac rehab center, if a male had a heart attack, his wife was often there at his side. When the female had a heart attack, never really saw the husband. Maybe they were passed away or they didn't come. One thing I must also highly mention is that there's more information now on physiology in women and older women, but there's still very limited data. All the cardiac rehab for the most part is based on males. So anyone interested in doing graduate work and doing PhD and postdoc work, really we need to focus on the older cardiac patient as well as older women. It's really the unforgotten group in cardiac rehab. And again, we need to start by exercise prescribed by a healthcare professional. We have to think about cardiac risk factor modification, education, and counseling, as well as psychosocial assessment. In the studies that I've done, I usually have people exercise in groups because the subjects love working. They love working with our team. They love working with the graduate students. Exercise is painful sometimes and boring. People always have a story to tell, and we always like to listen. We have good laughs. It's a social. So I do physiology, but I really fail miserably in my research because I'm not a behavioral scientist and I'm not looking at the psychosocial component. I really need to work with behavioral scientists more and maybe do some mixed method studies to say, we have to find out what people like to do and get them to do it. Why aren't they coming to rehab? Because I don't like this kind of exercise. Well, did you know that just, getting out of your chair and walking to the fridge is activity? So we really need to look at the psychosocial and behavioral modification, looking at goals, education on comorbidities. Diet is critical, nutrition, thinking about exercise, nutrition, group support, and stress management. And again, components, as you're well aware of, cardiac rehab is multidisciplinary. It's usually supervised to start off with. There's some nutrition guidance, psychosocial evaluation. If you're lucky, lifestyle modification. We need to incorporate some aerobic training and strength training, doing activities that people like to do. Gardening is even physical activity. It counts. Climbing. It doesn't have to be formal, getting on a bike on your Peloton and going for 2 hours. Even if it's for 1 minute and you take a break and do it that 20 times, that's 20 minutes, that's valuable. Here are some guidelines again, but you have to be careful with guidelines because if you use just a certain heart rate reserve or VO2 reserve, if you're very deconditioned, you might be prescribing exercise between bed rest and putting your shirt on. Strengthening is critical as well for people who don't have any contraindications to doing this because we lose muscle mass. And again, here's just some guidelines. They suggest 5 days a week of aerobic, moderate intensity, maybe some high intensity. High intensity, those all relative to your fitness level. When your fitness is 15 mils per kg, making your bed and dressing is 60% of your peak. So in fact, for the most deconditioned individuals, interval training really is key because that's how they're living. They do 1 little minute of making their bed and they take a break. Well, that's 60% of their peak. Putting their clothes on is more interval than high intensity because they don't do it for very long and it's a high level relative to their low fitness. It's not like you have an elite athlete and get them to now exercise on a bike at 500 watts. We're talking making your bed or one leg kicking at 10 watts. That could be 70% of someone's peak VO2. Again, they should do some strengthening exercise, gradually increase the resistance, and working on balance and proprioception where they can, as long as they don't fall. Safety is a key. And again, we want to do type of exercise that people like. So in summary, our HFpEF patients have severe exercise intolerance. It's due to both cardiac, pulmonary, vascular, and peripheral abnormalities. that result in a lower oxygen transport convectively and diffusively. We have lost lower leg blood flow, lower muscle mass, decreased capillarity, decreased oxidative enzymes, and a greater amount of intramuscular fat. These are all deleterious when you're exercising or getting off the toilet or climbing up a flight of stairs, because this now requires that older individuals, HFrEF or even HFpEF, now require on a different substrate to fuel the energy, which leads to byproducts of fatigue. Exercise training can improve this. It's safe, it's efficacious, it improves your peak VO2, it improves functioning, it improves quality of life, and it appears to date that this is due to non-cardiac peripheral adaptations. So I will stop there, and if we have a few minutes for questions or some discussion or dialogue, or if there's something that I may have said too quickly that you would like me to repeat, I'm happy to do so. And it's just a pleasure, Kathy, to spend an hour with you and your group, and I miss you guys.
Well, you need, now that COVID is hopefully going away, maybe you can come back and visit in person.
Well, definitely I will.
We hope for that. I have a question, and I'm open to anyone else asking questions too. But you know, one of the things that you pointed out is that persons with HFrEF typically have a lot more intramuscular fat, and they're often obese. Okay, the reducing that obesity would reduce their cardiac workload. However, losing weight is primarily a function of nutrition and not exercise. Even if you increase exercise, it doesn't impact weight very much. So how, I mean, what is a reasonable amount? And if it's just restriction in calories, you lose equal amounts of muscle and fat. So what is a realistic expectation for helping an older adult to decrease their fat mass, if possible? Is that even possible?
Yeah, so it's a great question. So we published a paper, Delane Kitzman was the first author in JAMA a few years ago, and the trial was with HFpEF patients. And there was a control, a group that was caloric restriction, a group that was caloric restriction and exercise, and exercise alone. And you're correct. So there was a reduction in fat mass. But you made a very interesting and correct point, Kathy. What we also found is you also lost some lean mass. So again, I'm not an expert in nutrition. We should have actually maybe invited in the future Wes Tucker worked with us.
Yeah.
Wes is actually a nutritionist. So
Right.
I also fail miserably because I don't incorporate nutrition. I talk about exercise, but if you go home and eat a Big Mac, then you got to get on the bike for 3 to 6 hours. So the trouble is we have to have a nutritional component to it. The trouble is that when we did the caloric restriction, we also lost lean tissue. So probably we got to encourage specifically some strength training. Do you know what I mean? Because that's critical for the age loss in muscle mass. And in fact, in postmenopausal women, we published a study in Journal of Gerontology years ago where we had 4 groups: control, aerobic, strength, and aerobic and strength. And we were really interested in cardiac function. We didn't measure anything in muscle, which is really unfortunate. Although back then I was very cardiocentric, and it's been 2 decades for me to realize, even in cardiac patients, the heart's a problem, but it may actually not be the most important problem when you have exercise intolerance. But what we found is for our primary outcome of VO2 and strength, the best group was combined training because they did double the work. But believe it or not, the next best group was strength training alone. The group that never rode a bike still improved their VO2 and their strength. So I think we have to have a nutritional component, and I'll have to leave that to the nutritionists. But key to that is we need to increase the strength and lean tissue as well.
Right.
Now, what's interesting is we also see, though, in people who are not necessarily obese, they still have intramuscular fat.
Right. Yeah.
So we always think of someone who is maybe obese or morbidly obese, but we do also see people, and even some of our breast cancer survivors, who their BMI isn't not necessarily that high, or let's say 30 or over, but they still have high IMF skeletal muscle.
Yeah. Yeah.
So there we've got to talk about some nutritional intervention as well as exercise. And I actually think exercise is more strengthening and isolated. But you've raised a critical point. Nutrition is key, but nutrition alone without exercise, you lose muscle mass. With exercise, you still lose some lean tissue. So we have to phenotype our HFpEF patients to what their needs are, which is difficult to do, and we can do well in our labs, but not for the general population.
How do we
But
do
of
that?
course, our HFpEF patients really have to watch their diet, right? Their sodium, and often there's a reason why they're a HFpEF, the lifestyle has led to where they are. So we have to change, and that's why it's so critical that multidisciplinary team is key. But we don't do that, because even in our cardiac rehabs, if people aren't referred to, they don't go.
I think that's it backs up to the whole paradigm of the way we deliver healthcare, and in individual people connecting with one patient at a time instead of a team and everybody wrapping their arms around a patient. That we don't do it that way. We don't think that way. There's some great questions in the chat.
Sure.
Here's one. Do you have any criteria that you would use to include or exclude HFpEF patients for cardiac rehab?
Well, I mean, I think anyone theoretically for cardiac rehab can be referred, at least in Canada they can, but the cardiac rehab team will, they'll make, there's certain criteria, like this article that I cited right here, by Boskert. It's just the 2021 paper. They can highlight that, but obviously we want clinically stable individuals. I mean, so if people are, NYHA class 4, they're not going to be encouraged to do it. And if they're, short of breath or fatigue, if they have some sinus tachycardia, if they're decompensated, if they've got some arrhythmias that obviously need to be in check, but ultimately, it's the referring primary care physician, A&P, or maybe a specialized heart failure nurse that will refer. But I would kind of maybe answer it this way. I don't think there's anyone who can't benefit from cardiac rehab, though, but you have to be clinically stable. And if you're, even in our heart failure patients, remember, Kathy, our assessments. How are you doing today? Have you gained any weight in the last day since we saw you? Have you gained more than 2 or 3 pounds? Are you more short of breath than normal? Has your heart rate started to increase? So we do great physical assessments and research before every session, and we monitor our patients. So it's key and critical that they're clinically stable, and you have to always assess the patient before any exercise session for those 4 or 5 key questions, because if they're yes, no, you can't exercise today.
So if they're doing it at home, you have to teach them to do a self-assessment before they.
Just like we tell them, listen, you need to know how to take daily weights. You need to know how to assess how much sodium you're taking. You need to know how to take your pulse or your rate of perceived exertion. If you feel more short of breath, if you're fatigued, you've got to call your heart failure team. The thing with a lot of our heart failure patients don't know what heart failure is. And they think when they now are finished with their decompensation that their heart failure is done. I don't have heart failure anymore. Well, unfortunately, it's a syndrome that you have for life. But many of our patients don't know that. So it's really, again, it's back to education. And finally, for research, we really need to, I was at a conference a few years ago now, we really are realizing we need to connect with the geroscientists and the geriatric cardiologists, because they are so well trained in the area. And especially many of our heart failure patients are frail. And it's
another comment in here brings up that very point. They're not just frail, they're multi-morbid, they're complex. And so you can't really study just heart failure in a lot of these patients, because they don't come with only one problem. And if you just want patients who just have that and nothing else, you're going to have a real hard time, and that's not going to be a very generalizable sample to make statements about, because they don't represent the norm.
So Ben Levine has the beautiful paper that he published in, I think, the European Journal of Heart Failure, and they screened 5,000 patients, 2,500 were HFrEF, I think 25 were HFpEF, I forget. And then when you rule out CKD, morbid obesity, pulmonary disease, sort of frailty. He ended up, I think, with 12 or 15. But the purest HFpEFs in the world.
Yeah, but
So they're the purest phenotypes, but you're right. And you've got to choose your HFpEF. Are they a COPDer? Maybe they just have hypertension or pulmonary hypertension. Maybe they're just a CKD. Maybe they're the obesity phenotype. So some of our HFpEFs maybe not even HFpEFs. Maybe they're deconditioned, obese individuals who are short of breath. So unequivocally, our HFpEF, yes, and our refs, but they have so many comorbidities, you often have to treat the comorbidity underlying the phenotype.
so and this is a great question. Do patients who have HFrEF benefit differently than patients with HFpEF? Are they equally benefit?
So they are
Or
equally
different?
they're equally beneficial as far as improving as far as improving VO2, but the mechanisms whereby they do so are both central and peripheral in HFrEF and peripheral in HFpEF. But I also have to say this: beta blockers, ACE inhibitors, angiotensin receptor antagonists, they also improve survivorship in HFrEF and not HFpEF. So to what extent is it also the therapy as well?
Yeah.
But the evidence to date would, and not every HFrEF improves
Yeah.
cardiac or vascular function,
Yeah.
but the seminal studies from Germany, Italy have shown that there are some central cardiac adaptations in REF that we do not see to date in.
Oh, okay.
So it seems more periphery, which we improve in HFpEF.
All right. One last question. What kinds of modifications, exercise modifications, would you recommend if the HFrEF person or HFpEF, the heart failure patient, has either osteoarthritis, which may limit their ambulatory ability, or low back pain, chronic low back pain?
Yeah, it's a great question. So if they can tolerate some aquatic therapy where they're unweighted, you just have to be careful because of hydrostatic pressure now, you've got more volume coming back, right? That's why you pee in a pool, right? Not that I'm saying you do, but you get in a pool and you get this hydrostatic pressure, you get increased end diastolic volume, stretches the atrium, adrenatic peptide, and you're like, oh, I've got a void. So you have to be careful, but varying levels in the pool, if they can tolerate not short of breath, you're unweighted, or isolated one limb exercise at a time. Like I said, why I love that is because you're never limited by your heart. And the classic study, the small sample of HFrEF patients by Russ Richardson at Utah, remember I showed that picture of one leg kicking, and I said they actually got HFrEF patients to exercise on a cycle ergometer, one leg, with that modified knee extension, like kicking your leg out. It's not cycling. For 8 weeks, they measured their VO2 on a bike pre-post. Their fitness was way lower than a healthy control, age matched. After 8 weeks of isolated one leg kicking, where they were never on a bike, their fitness went up to the extent of a healthy control on when they tested them on a bike, even though they never trained on a bike. So I'm a firm believer you need to train one muscle at a time, aerobically or strengthening, and then your heart's never limiting, your lungs are likely never limiting. Hopefully your back's not limiting. And then you get a whole body workout, one limb at a time, and you improve your fitness as if you were on a bike.
That is really cool.
Yeah. So we have to think outside the box in rehab. We're so structured that, no, it's easier to get everyone on a bike and a treadmill. Well, forget it. Because the minute you put a HFpEF on a treadmill, their muscles can accept 240 mils per kilogram of tissue. So anytime they exercise more than 6 kilograms, their heart is always limiting. So maybe some water therapy if they can tolerate it, or isolated training.
So if you're a clinician in practice, those are the kind of referrals that you might consider, is for water therapy, aqua, whatever, wherever you can find it in your community. So,
or Elisa's yoga, some stretching, what I mean?
Right.
Just starting slow, getting some fitness up, getting some proprioception and balance improved, some flexibility, and then you start strengthening. Then you get on the one leg, then you get on a bike. Right. Remember, the take-home message is here is when you're deconditioned, as 90% of our patients are, Making your bed or putting your clothes on requires 60% of your effort. That for me is running basically a 5K in 40 minutes. That's the equivalent. That's how they feel. They feel like they're running a marathon making their bed.
Um, are there any other questions? I'm monitoring the chat. I haven't seen any others. This has been really great, Mark. Um, it's invigorating to hear you again. So
It's my
I
pleasure
hope
to
everyone
see
else is
everybody.
enjoying.
And I'm happy. You can email me. You can find me on the internet, mark.haykowsky, Alberta. Happy when COVID's over for have anyone. We get Kathy and Elisa have to come visit, or,
Well,
happy to answer any questions. And it's just been a pleasure. And I hope it's been a worthy hour.